So the age-old question, welcome everybody, when do you stop drilling? We've been doing this since dental school, probably late sophomore year, early junior year. Sounds simple. And in actuality, it's really not. It's probably one of the most subjective daily procedures each of you do every day. And I would say most people do not do it in a similar fashion. Yet our decisions, they have a huge impact on long-term outcomes for the lifespan of our patients' teeth, which we're going to get into. Because I won't say we live in a culture of over drilling, but when you look at all the Facebook posts and you hear how people are talking, you're going to hear a very conservative approach tonight. So as you start to look at these cross sections of teeth, you start to really understand the caries nature of how it really does spread. Mesial and occlusal caries on an x-ray and how deep in actuality they are. X-rays underestimating decay. Here's a mesial and occlusal. A young patient with rapidly advancing caries, cross-section. Each and every time, I would say, when do you stop drilling? And what we thought was right and how maybe I was trained back in my day, and now I know it's different, but yet how do we do this? So the rationale was that we would take out all the infected dentin, then you'd remove the demineralized, discolored brown dentin, then you'd also go for bacterial removal. And the idea was that you would remove caries such that they would be stopped pretty much from progressing, and then you would be allowed to place your restorative material. And there is no evidence based with scientific rationale that this is legit. Yet people drill, take way too much dentin away, and this is pretty much common both in the US, Canada, and really all over the world. So welcome to tonight's course on selective caries removal. I'm going to take questions at the end. I may not have every answer. I'm not a cariologist. I'm a general dentist with 3+ decades in the chair. I have always believed in getting teeth to their 75th birthday. So molars come in, your first molars come in when they're 6 or 7. My goal is to get those teeth to their 81st or literally to a patient's 81st birthday. And it really then is talking about really what is the best way to take out decay and how does this really alter the lifespan of a tooth? Simply put, you over drill, you cause a root canal, then you do a root canal, routinely then you do a crown, you take away all the enamel, and how long will that root canal last? How long will that crown last? And again and again and again, you get into this vicious cycle. My whole idea of this tonight's approach is to avoid that vicious cycle as often as we can. So let's start with the feel of dentin. It's just not that simple. So let's start with soft dentin and understanding it is infected dentin. And it's considered the outer part of dentin caries. We're going to go through this. It's the most superficial, it's the most necrotic, and we term it irreparable. And routinely, you can just scoop it out. You need very, very little force. Then you get to the next layer, the leathery dentin. And this can have 2 layers. And we're going to show you the 2 layers in a cross section. Leathery dentin represents the outer layer of caries affected dentin. And it actually does contain collagen and mineral. And it can be remineralized. So if there's any question, though, to remove this leathery caries affected dentin and you're approaching the pulp within a 1 to 2 millimeter range, what you're going to learn tonight is leave it alone. don't go close to the pulp. Just leave it alone. Leave it alone. Nobody's overlooking, nobody's watching over you. You're all professionals, and that's what we're going to be talking about tonight. Beneath the leathery dentin, you now get to firm dentin. And this is considered the inner layer of caries affected dentin. And routinely, it's physically resistant to hand excavation. Ultimately, hard dentin. You really can't remove hard dentin unless you're really using a drill, so to speak. It's not going to lift off. And if you take an Explorer, you're going to hear a scratchy sound. So all too often, dentists keep drilling the pulpal floor until they get to hard dentin. And yes, it's okay to do that if you're not approaching what we would call the safety zone of really 1 to 2 millimeters of remaining dentin thickness between the pulp and your pulpal floor, your dentinal floor. So let's do a little cross section here. So you get a cavitation, and as the caries spreads, you get this soft infected dentin. And understand this soft infected dentin, and you're going to see why there's a story here. There is no mineral or collagen left. Now we get this layer of partial demineralization, partial demin, and this is your leathery dentin. And as you look, there are 2 layers here. You have the affected dentin, and that has some mineral and content. That's in the lighter blue. And then the darker blue is the inner layer. It's now really the firmer inner layer of caries affected dentin. And what's really important to understand here is that the dentinal tubules, as you're going to see this in some of our statements, the numbers get smaller and smaller. Not the tubules, I'm sorry, the odontoblasts, which are your reparative mechanism. So you've got infected dentin with no mineral or collagen, affected dentin with some, and firm or caries affected dentin that's deeper with more mineral. And that becomes critical, and we're going to get to that. So let's talk bond strengths. If you're bonding to caries infected dentin, the soft dentin, you're going to get incredibly low bond strength, pretty much about 80% lower than hard dentin. It goes back to the concept, you can't bond to infected dentin. You just can't. Now, there are solutions which we will approach. The bond strength to caries affected dentin is about 1/3 lower than bonding to hard dentin. So you've taken out the soft dentin, the soft decay, that's the infected dentin. And now you're getting more into the leathery or caries affected, and you're going down further. You get about 2/3 of that bond strength. The key, and here's a key takeaway tonight. The goal of selective caries is that the preparation around in the surrounding enamel really must be in 1 to 2 millimeters of hard dentin, because that's your peripheral seal. The selective caries approach is really dealing with just the pulpal floor. Okay, so statement 1, the unnecessary removal of healthy tooth structure routinely is dentin. Routinely. Now, we'll talk about enamel removal, but routinely it's dentin. And when you over drill and you're taking out your caries and you're using a low-speed carbide burr and you're taking away healthy dentin, it's really collateral damage. And you're getting closer to the pulpal tissue. You could be creating potential fractures of the tooth and other issues. Statement 2, selective caries removal will arrest the caries lesion activity. So you're going to reduce the idea of a pulpal exposure, and you're going to preserve the odontoblastic activity to repair the tooth. Okay? We're going to get back to the odontoblastic activity, I think, in statement 4 or 5. The endpoint of caries excavation and removal is really determined by the depth of the caries lesion. And you do not want to violate the safety zone of the remaining dentin thickness. You just don't want to violate that zone. And we're going to show you. The thickness of dentin really does affect the pulp vitality. So if you have an asymptomatic patient with deep caries and they have just some mild transient cold sensitivity, there's no reason to encroach on the pulp. The literature for almost 60 years has said partial caries removal is fine. You can leave infected dentin. Now we're going to show you kind of some ways to approach this. The remaining dentin thickness, okay, as you go deeper near the pulp, you have fewer and fewer odontoblasts. Odontoblasts are your opportunity to create reparative dentin. So once you're a millimeter, 2 millimeter, once you're really getting closer to that pulp, you have less reparative mechanisms. So this was a study just a couple years ago. And I love the saying, it doesn't matter what is lost. What matters is what remains. And what remains is dentin thickness. Now, as I went through the literature is really interesting because Pomerger said that the remaining dentin thickness needed to be greater than 1 millimeter in order to protect the pulp from really the cytotoxic effects of certain restorative materials such as zinc phosphate. But you can get cytotoxic effects from bonding agents and composites. So these are not innocuous materials. Stanley, almost a decade before, said you needed 2 millimeters of remaining dentin thickness. Then you flash to 2003, Murray said you have to have more than 0.5 millimeter to avoid pulpal damage. And lastly, Fuchs showed if you're within 1/4 millimeter, then the bacteria are present within the cavity really can cause an inflammatory reaction in the pulp. If you can see that little red hue of the pulp, you've gone too deep. You've just gone too deep. And on an asymptomatic patient, you can shoot the messenger. It's not necessary. There's no reason to pulp out based on the literature. Statement number 5, it's not possible to determine the remaining dentin thickness from an X-ray. You just can't. And what happens is you think a cavity's deeper, and we've all learned this. It's actually deeper. So if you see a deep cavity on the X-ray and you think, oh, I've got 3 millimeters between the bottom of that cavity and the pulp, routinely it's about 20% worse. And rarely is it underestimating. So think it's a worse situation when you're going to open it up. The key is a well-sealed restoration. You got to have the entire border of your restoration sealed. If you do that, you will entomb the microorganisms, deprive them of their nutrition, and this will lead to an alteration of the flora, arrest caries, and you'll get a hardening of soft dentin. So I'm going to go a little in a different direction. I want to talk about the hardness of tooth structure. The hardest part of a tooth is enamel, and it's got a barkal hardness maximizing around or peaking around 430. Healthy dentin is between 70 and 90. Okay. And then infected dentin, as we said, is very, very soft. So when you look at the hardness scale, a carbide burr has a barkal hardness of 1600. So when you have a barkal hardness of 1600, the predecessors of my generation were using belt-driven handpieces. You could drill through enamel, do a crown, would take a while, but it was because the barkal hardness of a carbide burr is so much harder than enamel and obviously dentin. So here's the key. Even at low speeds, a carbide burr can easily remove healthy dentin while you're trying to remove the infected dentin. So now the question, how do you best accomplish selective caries removal? Then the next question, are there options with dental burrs in regard to effectively removing infected dentin? So as I have, and I'll walk you through this, as I prepared for this course and did literature reviews, I found this particular article to be very interesting. And this article evaluated removing caries with 3 different burrs. And the first being the tungsten carbide burr. And I want to walk you through this. So in this burr group, in red, where the red arrow is, what it's saying is it had the smallest residual caries from the initial caries, which means a tungsten carbide burr left little caries remaining. It did its job. Because it did its job, it removed the caries. It got down to what we would call firmer dentin, which has a higher mineral density. And so you could bond to it. But it was also seen to be maximum in its invasiveness. There was a lot of collateral damage. It drilled away good dentin. So that was the tungsten carbide in this study. Then there was this sonic system with a diamond head called Excavus. Some of you may have used this. And what's interesting, it had the highest residual caries rate. So you start with the cavity, and the residual caries were actually the highest. It didn't take away the caries. Because it didn't take away the caries, you had a low mineral density, meaning you were dealing with infected dentin, which doesn't have mineral. But yet it was also termed the least invasive. So you have the least invasive with this group called Excavus, which is a sonic way of removing caries, but it didn't really remove a substantial or a necessary amount of the caries, the initial caries. The third burr is a burr I've been using for 10 years, and it's called the Cerabur. It's made by Comet, and this is a game changer burr. If you haven't used this burr, this is a game changer. If you have used this, congratulations, and I mean that sincerely. This burr, which I will show you in a few minutes, had a very acceptable residual caries removal from the initial caries. It removed the majority of residual caries. Based on that, it had a good mineral density, meaning it removed enough of the residual caries, initial caries, so you could bond to good tooth structure, or what we would say caries affected dentin. And I want to show you one more. I'm going to go back. On a minimally invasive side, it was considered very, I would say, much closer to ideal. So when you look on the left and right in the way this study was done, Excavus on the right side left the most residual caries. TC is tungsten carbide, and it left the least residual caries, and the Cerabur was very, very close to the tungsten carbide. So let's talk about the conclusion. The majority of you are doing caries removal at around 10,000 RPMs with a carbide burr, slow speed. And it is still a what I would call a common method of choice for removing caries to get you to an ideal substrate to bond to, in other words, mineralized dentin. The Cerabur, with its mechanical properties, was considered an alternative by the conclusion of this study, and it was looked at as not as invasive as a tungsten carbide burr. And the Excavus group left too much decay. So I'm going to continue to harp on the fact that this Cerabur was not as invasive as a tungsten carbide burr. So here's the Cerabur. Now, I want to be clear tonight. There's no sponsor here tonight. Catapult Grow, our GPO, and Dental City marketed this course. There is no funding for this course. There is no endorsement, sponsors, nothing. These are the materials that I have used in my practice, and they go along with the technique. For over a decade, I have been using this burr. The burr is composed of zirconium and aluminum dioxide, so it's really a modern-day ceramic burr, and it's stabilized by yttrium. Its recommended speed is 1,000 to 2,000 RPMs. It's like rotary endo speed. Obviously, it's faster than rotary endo, but you actually see the burr slowly spinning, removing the decay. It's totally different than removing decay at 10,000 or 20,000 RPMs. In this case, you can set up routinely if you have an electric system in your office. I'll show you alternatives. If you have electrics, you just hit the preset of 1,000, 1,500, or 2,000. With the NSK, you can lower the torque and you can lower the speed. And I believe in lowering the torque because you want this to be a very non-invasive procedure. The Cerabur comes in 8 sizes. And this is really what you see when you start removing infected dentin. You start seeing these shavings come out. And as you go a little bit deeper in another preparation, the shavings get smaller. But now you start to identify there's your caries affected dentin. And as we look at it, I can tell you it's mineralized. This is the deeper layer of caries affected dentin. Stop drilling. Just stop drilling. And if the decay was deeper, I'm going to give you recommendations to that. So this is the kit. And this is in each of our rooms at our office, or you can use this kit to autoclave your burs. And routinely, the first question is, so don't ask the question yet, how long do they last? So in the study by Queen Mary University of London, these burrs can actually last 3 times longer than a typical tungsten carbide burr. So they're autoclavable. And routinely, they'll break unless you literally hit it at the neck. But routinely, they just do not break. Over time, the blades will bald a little, but we're talking a long time of use. So these burrs are very efficacious. They do exactly what they're supposed to at 1,000 to 2,000 RPMs. Now, let's say you haven't gone electric. So when I'm teaching this to my audiences, I want to give you options. This is what we used for years before we went electric in my office. So we were doing rotary endo, and this is EndoMate. Again, it's by NSK, and our office is an NSK office. I know there are many great systems. We think it's a great manufacturer. You have 5 preset speeds. It's got the ideal torque for caries removal, and you can charge it in a very fast, I think it's like a 90-minute charge. So when you're doing caries removal, you're using this for 1 or 2 minutes. It's not like if you're using this for 30 minutes, you're going way too slow. So at 1 to 2,000 RPMs, it's just kind of going in its own path. If you don't want to go that route, routinely, you can get 10-to-1 gear reduction attachments for your contra angles. Most companies make a 10-to-1 gear attachment. NSK makes one such that, as I'm showing you here, you can get this attachment. I think it'll fit most handpieces and immediately gets you down to 2,000 RPMs. So there's no excuse if you're an air-driven office not to be doing selective caries removal. Now you could say, Lou, why can't I just use a carbide burr at 1,000 RPMs? Again, it's got a Barkle hardness of 1,600. And even at 1,000 or 2,000 RPMs, it's going to take unnecessary good dentin away. So here's my case. And I could go through dozens of cases, but here's my case. So about 20 years ago, I had a new patient come in. She was 26 years old. She was actually working in the dental industry, referred by her sister, who was also working in the dental industry. She had no restorations, great home care, orthodontics as a teen. She'd seen her dentist routinely since she was a few years old back in New Jersey, and her last visit was 8 months ago. The dentist happened to be her dad's older brother. So she comes in, and I'm at the time using Logicon. I think it was by Kodak. It was my first entry into digital. I was using Diagnosing by Cavo for caries evaluation. I still think it's a great system, far more accurate than an Explorer, which is what I'm going to get to. So here's Logicon. This isn't Pearl or Overjet. This is like a predecessor. And this is already 25 years old. Logicon identifies this millimeter by millimeter, evaluating it, and there was no class 2 decay. I really couldn't see anything on the x-ray. And what did I trust more? An Explorer or a Diagnosing? And the answer is, for any Diagnosing user out there, we all know we're going to trust the Diagnosing far more. If you micro etch and remove any stains, it's even more accurate, but the accuracy is dramatically better than an Explorer. And if the reading is over a 25 or a 30, I'm concerned. In this case, it was a 58, so I knew there was caries. Clinically, there was no stick. You could see a brown halo. I could see the brown halo, but no stick. And it takes me back to the decline of the Explorer. Traditionally, this was the decay model. Caries would attack. It would begin in the enamel, cause demineralization, and subsequent cavitation. And then your Explorer would stick in the cavitation. Here's the model. Acid attack through the enamel, and then expansion through the dentin. Well, what happened? Fluoride came. So enamel may not cavitate because of remineralization, but the caries process will continue. So what happens is you get micro leakage through the fissure. Your Explorer can't explore that area because it's remineralized. And so what happens is you go in and all of a sudden, boom, you see a big cavity and you go, how could that be? This is how it could be. So it's spreading below the surface that has remineralized. So this is what happens. It remineralizes, the Explorer doesn't stick, and the decay just laterally spreads. So I go in, my initial entry with a small fissurotomy burr. I go right into the halo, and that I've already opened up the halo. I see that, and this turns into this. Now remember, she's 26 years old. When you look at the x-ray, and there are things going on here, the distal pulpal tissue is already receded. So I already know this caries has been there for years. This is not something over 8 months. So I go back to the question, when do you stop drilling? So when we look at selective caries removal, this happens to every one of you. And whether you're doing a core buildup for an onlay or a crown, or you're doing a class 1 or a class 2, it's everyday dentistry. Class 3s, 5s, you name it. So I'm going to go in at 200,000 RPMs with routinely a single-use diamond, and I'm going to go through my enamel and really create my entryway into the infected dentin. I routinely dial down to 50,000 RPMs. It's another preset. And I really do my initial caries removal a little bit slower at 50,000 RPMs. At this point, I'll dial down from 1 to 2,000 RPMs. And routinely, if it's a mole or a large cavity, I'm going to use a number 8 Cerabur. If it's an anterior or lower central, I'm going to use a quarter round or a half round. This is why you need the arsenal of the Ceraburs. So as I'm dialing it down, I'm going to continue removing all the peripheral decay on the walls, along with removing the remaining infected dentin on the pulpal floor. But there's a caveat. Here's a key caveat. You got to know how deep this cavity is. Because if you're just going to continue to remove all the infected dentin and it's really, really deep near the pulp, you've over-drilled. And I'll show you this diagram on a diagram. So you can remove all the infected dentin, which I'll show you. In this case, it wasn't near the pulp. I had a good amount of remaining dentin thickness. That's the key. So what you're going to do is you're going to assess the area. If it's moderately deep and you've got really more than 2 millimeters of remaining dentin thickness, just remove all the infected dentin. You're good. You're good. The studies confirm that. You may want to use a smaller Cerabur to get to an area, but you're good. You want to verify all your peripheral walls, all along your enamel, are clean. Now you're going to assess the area if you're approaching, let's say, if it's deeper. If it's deeper and you're getting within even a millimeter of what you think is the pulp, stop drilling. Just stop drilling. There's no reason to pulp out. None. And again, the literature for 60 years says it's okay to leave infected dentin. Don't violate the remaining dentin thickness. So here's her. This is her. This is Mel. She's got a moderately deep caries lesion. So you can see where it's soft and firm, then hard. It wasn't approximating the pulp. So I could remove all the infected dentin on the floor and get down to caries affected dentin and just stop. Well, what if I added a blue little area here, and now I'm closer to the pulp, and I may only be a millimeter or less away? This is where you're going to leave infected dentin. You're just going to leave it. You are not going to drill it away. If the soft infected dentin was deeper, like you'll see here, if you look at the diagram, look at how deep this decay is. By the time you get down to firm dentin, you could be violating the biologic, you could be violating the remaining dentin thickness of 1 to 2 millimeters. So what does that mean? You're going to have to come up with an alternative way. So think of this as your son or your daughter. They're 26 years old, or it's your wife or husband. And do you want to pulp out on a 26, a 30, a 35-year-old, 40-year-old? The answer is no. So very often in this case, I may do an interim restoration. I'm going to leave more infected dentin, and I'm going to use silver diamine fluoride, and I'll place a glass ionomer over that. I'm not going to teach the technique tonight, another course. But I'm going to use silver diamine fluoride. I'll show you this as we close tonight. And then I'm going to do an interim, routinely like an interim restoration of a glass ionomer or a resin-modified glass ionomer. The enamel. To create the peripheral seal, you have to remove all the infected dentin. And once that is done, it may be beneath the enamel margin. So you may have to remove the dentin below the DEJ, and you'll see it has spread. And what will happen is you'll have unsupported enamel. So what do? Get out articulating paper and have the patient bite down. Go into excursions. Is the patient biting down on unsupported enamel? You may then want to remove some of that unsupported enamel, especially if they're a heavy clencher grinder. The occlusion is more challenging. They've lost some molars. So it's up to you how much enamel you want to remove, and I often base that on occlusion. Cleansing. So now you've taken out the caries, and in this case, I've taken out all the infected dentin. I am not using silver diamine fluoride. So this is a product that I would say 90% of you have not heard about. We use this a lot for our perio patients. It's another presentation, but this is made by Epion. It got huge kudos from our evaluators, both for perio, but also for restorative dentistry. It's an acidic sulfur compound that we're going to use to clean the dentin. And basically, it is a plaque biofilm remover. And what it does is it goes in and it extracts the water from the bacteria. So you've got this remaining bacteria. It will go in and extract the water in really 20 to 30 seconds and give you an entire cleaner surface. It comes in a liquid or a gel. And as it cleans the remaining bacteria, it's also a desiccating agent. It's a desiccating agent when we're cementing crowns, and we do this before we cement crowns. You'll see the tissue dry up. That's beautiful because you don't want to be cementing a crown in moisture. But it also will remove the smear layer, and the studies show it can enhance bond strengths. So in this study, and it's already almost 15 years old, and this is well used in Europe for over a decade, Hybenex can be recommended to enhance bond strengths. So I went in and I took this study, and though it was at a presentation for peri-implantitis, and that's another indication for the use of this material, I want to show you how it really goes hand in hand with selective caries removal. So when you look at this, you're going to want to remove all the marginal decay. You're going to want to remove the infected dentin that is not approaching the pulp. This is not approaching the pulp. This is marginal decay. This is not approaching the pulp in the dentin. Get rid of that infected dentin. This area with remaining, we'll say caries affected dentin or infected dentin, probably more caries, is now approaching the pulp. Stop drilling. Stop drilling. You've got a beautiful peripheral seal. You're going to place the Hybenex into the preparation, and this is how we'll do it. 15 to 30 seconds. Then you're going to rinse. And what routinely I do is I get a surgical suction. I suction it out first. It tastes bad, by the way. Suction it out first, then rinse it with a surgical suction. Blot dry. You need to leave this mildly moist. So remove it all. And if for whatever reason the tooth is somewhat drier, you're going to have to then take a micro brush, dip it in a little dapping dish with water, wipe off the excess. And then what you will do is you will just paint a mildly moist brush, place a mildly moist brush, really mild, on the dentin. You'll see why. Because then you're going to place your liner. And there's a specific liner you're going to place. And it's called calcium hydroxide silicate liners. It's the only liners you're going to be placing. These liners have been really used for multiple reasons. The first is it's antibacterial. It's an alkaline-based product. So what happens? What happens is alkalinity leads to bioactivity. So as the calcium hydroxide breaks down, it will dissociate into calcium for remin and hydroxyl ions. The hydroxyl ions are alkaline in nature. And alkaline in nature is antibacterial. So when you put a calcium hydroxide liner down, it is antibacterial. Very, very important to know that. It's also, the monomers are very hydrophilic. That's why you need to have the dentin be somewhat moist. The calcium will flow because if the tooth is moist, it will just flow into the dentinal tubules. It cannot be placed, none of these can be placed on a dry surface. Lastly, there's no fluoride. Fluoride is toxic to the pulp. You don't want fluoride ever near the pulp. They have low solubility, so they actually protect the pulp from the cytotoxic effects of bonding agents, composites, and other materials you may be using. So let's take a look at the liners. They've really shifted over the last 10 years. The breakthrough was Theracal 10 years ago by Bisco, an amazing product. It showed a higher calcium releasing ability and a lower solubility than ProRoot MTA or Dical. It was a game changer. Higher calcium release and lower solubility. These are the players today. Ultra Blend from Ultradent, Theracal still from Bisco, Limelight Enhanced from Pulpton, Cerabur, Protect LC from Directa, and Calcimol LC from Voco. And there are probably others, but these are the only ones we've tested. They all offer the same exact properties that I've gone through in the radio opaque. What's interesting, we're getting more improvements. So Nate Lawson, who is out of UAB, who is working with one of my dear friends who passed, John Burgess, big loss to the profession. This study showed, as you look at that green line, that where the brown arrow shows calcium release and the purple arrow shows the axis of time or days with the XY axis, the number one calcium releasing product, pretty much clearly, initially and long term, was Protect LC by Directa, sold through distributors, not a direct product, which nothing wrong with it, of course, if it's direct, but just saying bought through distributors. And it's now been bought and sold by a company called Directa. So in this case, the caries were moderate in depth. They did not approach the pulp. I didn't need a liner. If I'm not near the pulp, I don't need a liner. So when you look at the approaches on how you want to restore this tooth, let's go back. You could do a bulk fill composite in 1 or 2 layers. So you bulk fill the composite, and then you put a capping layer. Let's go back again. Sorry, I'm a little ahead there. You could bulk fill with a self or dual cure material. This is hot today. There are many companies who are making these, and then you would put a capping layer. Why would you use a self or dual cure? Less shrinkage stress. Pure and simple, less shrinkage stress. Then you get a bulk filled with a fiber reinforced composite to minimize fractures. GC America makes an amazing product with fiber reinforcements, and it's called Everex Flow, an amazing product. And then you put a capping layer over that. You could rebuild this, as many of you do, in 2 millimeter increments with flowables and composites. And in this case, I decided to rebuild it. I rebuilt the Dentin with an RMGI, and then I placed a capping agent. Why? I'm looking for the long-term fluoride release. I've been using RMGIs and GICs, glass ionomers, for decades. And when I've gone back into restorations and removed the resin ionomers, resin glass ionomers or glass ionomers, there's like no decay. So I know it's another step, but I'm always looking to do ideal dentistry. So I'll just show you this approach because most of you may not be doing it. I'll go in with a cavity conditioner for 10 seconds. You could etch for 5, but I use a conditioner per the DFUs. These are made by GC America and SDI. And these are RMGIs in my practice. GC Americas, SDIs, and Vocos. So here's the clinical steps. You're going to condition the tooth for 10 seconds, rinse, blot dry, inject the RMGI into the preparation. Wait about 30 seconds because it's too jelly. Let it start to get a little tacky. You're going to then dip your instrument in a pure resin, same as you're doing a composite. You don't want any solvent. I'll show you an example. And your work time is about a minute and a half to 2 minutes. They say a minute 50. You must light cure. This is a light cure material. And the light curing is 20 seconds. The dipping product could be Equia Forte from GC America. And this is Riva Coat from SDI. So I put a little drop in a dapping dish, and I'm just packing the resin modified glass ionomer with this. with my instrument that's just dipped in this with a little bit of resin. At that point, I'm going to re-prep. I only need 2 millimeters. So I'm going to re-prepare the floor and the walls. I may have resin-modified glass ionomer on the walls. The patient wouldn't even need to be numb now because the dentin's all covered. Then I'm going to use a red football finishing burr to create all my enamel bevels because I believe in enamel beveling. You get increased bond strengths long-term. The next clinical steps are after you've got enough room now for your final composite, you're going to etch, you're going to rinse, suction dry, blot dry. You're going to apply your bonding agent. Usually I use a universal bonding agent. Follow the DFUs, 10 or 20 seconds, air only, no air water syringe, air only syringe, and appropriate light curing. One option is you can place a flowable over the RMGI, light cure it. You could place the flowable and then a composite over it and do the snowplow technique. It's another technique. You could rebuild it in 2 layers. You could rebuild it just on the buckle and then the lingual, minimizing the C factor. There's so many different ways to do this. You just want to follow an approach. Or just warm your composite. And the studies show you get less stress when you use a warm composite. Again, I know it's a class 1. It's nothing fancy. All the universal bonding agents, I think they're all wonderful. In this case, I'm bonding to enamel and an RMGI. I'm not bonding to a Dentin metal zirconia composite. And you can bond these dry or wet. I mean, to me, I can't imagine not having universal bonding agents. Bottom line is, this is the final restoration. And you can see we were near the pulp. I didn't need a liner. Below the red line is my RMGI. Above the red line is my composite. I finished the case with the sealant. 7 years later, it looked ideal. And then she got married and moved. So let's sum up tonight. Then we'll take some questions. This is a typical deep caries lesion, transient to cold sensitivity. This is a deep caries lesion with what I call tooth parts that I can explain to a patient, and this is from Pearl. Pearl's AI is quite dramatic, but you can measure, and the measurement is about 0.79 millimeters of remaining dentin thickness. Well, we know then it's really about 0.5 because we have a 20% error factor. So now what are you going to do with this deep caries lesion? You have 2 options. You can drill, and once you feel you're about 1 millimeter to 2 millimeters away, stop drilling. Use Hybenex or a cleanser of your choice. Use a calcium hydroxide liner and restore it the way you want. Option 2. You do a 2-stage procedure. The decay is very, very deep. You don't take out that much infected dentin. You could leave 3 millimeters of infected dentin. And what you would do is you would do a silver diamine approach. So I use Revastar Aqua by SDI. There's no ammonia in it. I think it's such an amazing SDF product. So I etch the tooth, then I use silver diamine floor. I use the technique as per the DFU, and then I'll place an RMGI or a GIC, a glass ionomer. Have the patient go away. And 6 months later, I'll take out the glass ionomer RMGI, and I will not go in and rebuild, but I know that the caries has been halted, and I will then put a permanent composite over that restoration. And I'm billing for it. The paradigm has shifted, and it's shifted that caries removal should be a far more selective process, as I've shared with you tonight. You have enhanced diagnostics more than an explorer. You have new materials, and you have new techniques that continue to evolve to secure far more conservative approaches and stopping this, what I would call this circle of way too much enamel removal and way too much dentin removal. I'm going to thank you for your time tonight. This is my email. Obviously, this will be recorded, but you can send me questions. I'll take a few questions. And again, I don't know everything, but I'm happy to engage with questions. Okay, so with questions, let me go to Q&A. So the first one I'll go to, is there an ADA code for this? So let me be clear here. There is no selective caries code. But what I will tell you is I bill out all my liners. I bill out all my bases as an indirect pulp cap. So that's how I bill it out. So it's, if I do a deep restoration, one stage, it's an indirect pulp cap, and then it's a 2391, 2392, 2393. Okay, we got a lot of questions, which is great. So let me start. When a caries, and I'll read them if I don't know the answer. When a caries detect material is used, to what layer of caries detect does it get absorbed? I'm very careful with using caries detect materials. I use them for more craze lines and cracks. If you're going to use a caries detect material and it is absorbed, you are going to have to remove it because it will lower bond strength. So routinely, I'm looking to use, if you're using caries detect on the lateral walls, that's where I'm really looking at. I don't want to leave any decay on my lateral walls. On the floor, I don't use caries detect for the floor. I just don't. The Cerabur is an amazing technology where at 1,000 RPMs, you can just do selective caries removal. So comment on Manji's tooth cycle of life. I know you're anonymous. I respect Manji. I just don't know the tooth cycle of life, and I apologize. Okay, now another comment. Comment on Almond's 3 millimeter lateral caries removal endpoint and 5 millimeter pulpal caries removal endpoint from tip. I can't. Gary, you can absolutely email me. I'll do my best at discussing with you. I just, like I said, I don't know everything. What I presented pretty much is what I know. Comment on ozone gas therapy to help kill bacteria. I think it's a great approach. I think ozone, one of my close friends, Mark Maltrud, he's a big user of it, big believer in it. And I have no issues with ozone gas therapy. In fact, I think it's a great therapy. Is there evidence of how much residual caries are left using a 330 diamond burr? Well, again, you're using a 330 diamond burr at 10, 20,000. The residual caries, I'm more concerned about. Honestly, the study shows you're going to get most of the caries out, but how much dentin are you taking away? So I don't really use 330 diamonds for caries removal. What are your feelings on the diagnostic use of near-infrared diagnostics for caries detection? I will tell you, I was the biggest CariView user. I have CariViews in my practice. I think CariViews are far more diagnostic for interproximal decay than 2D X-rays, and the studies confirm that. You can get NIRI on like an iTero. I know it comes with an iTero, but if you're using NIRI, I have near red, infrared. I'm all over it. I think it's superior than 2D X-rays. What are your thoughts on using air abrasion for caries removal? Okay, Gary, let me just tell you this. I routinely use air abrasion on every endodontic buildup. So after you do your endo and you've got your cement and gutter perch and everything all spread throughout, you've got to bond to a clean surface. So I do absolutely use air abrasion. Size of the particles per the studies are not important, and it will enhance bond strength. When I'm cementing a crown and I've got a ton of cement on it, it's a non-vital tooth, I'm going to use air abrasion or Hybenex to get a clean surface. I'm not opposed at all to air abrasion. Just got to make sure those particles are gone. The example of occlusal caries under a fluoride remineralized occlusal surface. Shouldn't this be similar to sealing deep caries under a filling and cutting off the bacterial's access to nutrients? The answer is yes. So I believe, and this is my own personal, almost 4 decades, composites leak. Glass ionomers leak far less. So if you have any leakage under a composite, you have a resin modified glass ionomer, that is about the best wall to stop recurrent decay. And that's how I approach this. Does Hybeness designate dentinal tubules causing post-op sensitivity? The answer is no, doesn't penetrate that deeply. Comment on caries indicator. I previously did. I use caries indicator more looking at cracks and craze lines and lateral surface decay. I don't use it to remove caries along a pulpal floor. If I don't have Hybenex available, can I use chlorhexidine on the prep? Yes, probably 4%. There are others, but I would say Hybenex is available. I mean, it's through all your dealers. I would say it's a game changer. And we cement all of our crowns. We use this beforehand, and you're not dealing with gingival clavicular fluid. It's just an amazing product. I would definitely try it. It's not expensive, but yes, you can use chlorhexidine. What's the name of the cleanser you used? It is Hybenex, and it's made by Epion. Do you use a spoon excavator for caries removal? You can. But again, if you're deep, the answer is no. You know what happens? You get your spoon on a leathery area, you scoop up the leather, and all of a sudden a millimeter chunk of leathery caries affected dentin comes up, and there's your pulp. So routinely, I'm using the Cerabur now more than a spoon excavator. TheraCal versus TheraBase. Good question, James. TheraCal, like any of these liners, can only be 1 millimeter in depth, only 1 millimeter in depth. TheraBase can be used in a sense as an alternative potentially to a resin modified glass ionomer, so it can be much thicker. I've used TheraCal routinely in the past, but I will tell you, I'm just not a TheraBase user. I'm not negative on that at all. What's your experience with Soleil lasers for caries removal? I have two good doctors who I know well who do use the Soleil laser for caries removal. I'm 100% supportive. Why? It's minimally invasive. I think it's great. I know it's $125,000. I showed you a $4 burr. So I think CO2 lasers are amazing, and I do think the Soleil laser can absolutely do that. If you have more questions, I am more than happy to take your questions to my email, and it's lou@catapulteducation.com.